to the Skilled Nursing Facilities follow-up webinar on Section GG. The audio for today's session is available by telephone or audiocast. To accommodate as many participants as possible, this program is designed for web audio. For the best webinar experience, we encourage participants to listen over their computer speakers. However, audiocast quality is subject to equipment, available bandwidth, and internet traffic. If you experience unsatisfactory audio quality, please use the telephone dial-in option provided in your confirmation email. Those listening over the telephone will notice a significant delay between the audio and the slides. You may prefer to follow along with the slide handout. If you do not see the phone number in your webinar email, please send a message to the operator using the Ask Question button to the left of the presentation. You will receive a response by email. Assistance is available to those on the telephone by pressing #. You may send questions or comments at any time using the Ask Question button on the left of the presentation screen, then click Submit to send it. Individual responses to specific questions for assistance will be sent by email. Questions of general interest will be posted in the Q&A box, which can be viewed by everyone by clicking on the Q&A button on the left of the presentation. A PDF of the slide presentation can be accessed by clicking on the Materials button on the left of the presentation. I will now turn the call over to Sharon Purcell. Please begin.
Good afternoon, everyone. Thank you for joining us today for the Skilled Nursing Facilities Quality Reporting Program webinar. My name is Sharon Purcell, and I will be your host and moderator for today. Before I transition the presentation to Ann Dice, I will review a few housekeeping items. Due to the large number of participants on today's call, it was necessary to change our delivery platform. To ensure your audio is synchronized with the slides, we recommend using your PC to view and listen to today's presentation. If you experience audio problems on the PC and need to use the phone number and passcode provided, please download the presentation from the Materials button and follow along using the downloaded version of the presentation. This webinar is being recorded today. It will later be posted to the CMS SNF Quality Reporting Program web pages. We will provide you with details on accessing the recording via email when it is available. Closed captioning is enabled and will appear at the bottom of your screen. The audio can be controlled using the speaker icon on your computer taskbar in conjunction with the audio control of the webinar platform. The phone lines will be on mute for the duration of the presentation. Due to the large number of attendees on today's webinar, we are unable to field questions over the phone, but you are able to submit questions electronically. Click the Ask Question button on the left of the screen, type your message, and click Submit. Responses to technical questions can be accessed by clicking on the Q&A button. Responses to some content-related questions may be addressed in the Q&A document from the July 31st, August 1st SNF in-person training that will be posted to the CMS SNF QRP webpage soon. Please review the Q&A document when posted for responses. Other responses to content-related questions will be shared with and responded to by the SNF QRP help desk. If you would like to download today's presentation slide deck, click the Materials button located on the left of your screen to access the shared files. Training materials can also be downloaded from the Download section of the SNF Reporting Program training webpage. The Download section is at the bottom of the training webpage. A disclaimer has been provided for your review. Please keep in mind Medicare policy changes frequently, and please refer to the links provided in the presentation for the source documents. We encourage you to review the specific statutes, regulations, and other interpretive materials for a full and accurate statement of their content. Now I would like to introduce today's speaker. Presenting the Skilled Nursing Facilities Quality Reporting Program, Section GG, New Items, and Section I Updates is Ann Dice. Ann Dice, an RN, PhD, CRRN, is a Senior Research Public Health Analyst with RTI International. She is a certified rehabilitation registered nurse with a doctoral degree in epidemiology and community health. She was part of the team that developed the continuity assessment and record evaluation tool and was involved in training data collectors and data analysis in the Medicare post-acute care payment reform demonstration. Ann has an appointment as a clinical research scientist at the Rehabilitation Institute of Chicago's Center for Rehabilitation Outcomes Research, and is a research associate professor in the Department of Physical Medicine and Rehabilitation in Northwestern University's Feinberg School of Medicine. Please note on slides 7 and 8, we have provided a reference list of acronyms that will be used throughout today's presentation. We are pleased to have such an experienced and knowledgeable speaker present on today's webinar. And thank you for being here today. It is now my pleasure to turn the session over to the presenter. Ann, the floor is yours.
Great. Thank you so much, Sharon. Okay, so in terms of objectives, we're going to start off by reviewing new items added to Section GG, and that's the section Functional Abilities and Goals, as well as Section I. We'll also have an opportunity to practice instructions for the new items in Section GG and the new Section I item. So again, this is switching over to Section GG, Functional Abilities and Goals. So the objectives of this particular section, GG, is to articulate the intent of the new Section GG items, demonstrate a working knowledge of Section GG functional abilities and goals, explain item definitions and changes to some definitions, as well as apply some coding instructions to accurately code practice scenarios. In this particular section, then, we'll, in terms of overview, we will review some of the new items, including prior functioning, prior device use. We'll talk about the new Code 10. We'll talk a little bit about usual performance. We'll talk about the new items related to admission and discharge, self-care and mobility, and we'll also talk about discharge goals. The reason that we have new items added to the MDS relates to the adoption in the SNF quality reporting program of 4 new quality measures. And those were added to meet the requirements of the IMPACT Act, or the Improving Medicare Post-Acute Care Transformation Act, and these quality measures address the domain of functional status, cognitive function, and changes in function and cognitive function. So the quality measures use data elements currently coded on the MDS Section GG, and it also, these items were also added to address the standardized data elements across post-acute care settings. So the intent of Section GG, functional status is assessed based on the needs for assistance in performing self-care and mobility activities. Residents in skilled nursing facilities have self-care and mobility limitations and are at risk for further functional decline and complications because of their limited mobility. So in terms of data collection, the Section GG data are collected at 2 points in time. First of all, they're collected at the point of admission, and that is the Part A prospective payment system admission. And that is the 5-day PPS assessment, which is the first Medicare required assessment to be completed when the resident is admitted for a SNF Part A stay. This functional assessment must be completed within the first 3 days, that is the first 3 calendar days of the Part A PPS stay. and it ends at 11:59 on day 3. The second point of time for data collection is the Part A PCS discharge. So a Part A PCS discharge assessment is required to be completed when the resident's Medicare Part A stay ends, and that could be as a standalone assessment when the resident's Medicare Part A stay ends, but the resident remains in the facility, or it may be combined with an OBRA discharge if the Medicare Part stay ends on the day of or one day before the resident's discharge date. Just some general coding tips related to the admission and discharge. So the admission performance and discharge goals are coded on every admission assessment, that is the start of the Part A PCS stay, regardless of length of stay and whether the stay ends in a planned or unplanned discharge. If the resident has an incomplete stay, then you would complete the admission performance items and the goals items. The discharge, self-care, and mobility performance items are not required. And again, that's in the event that there's an incomplete stay. So on the next few slides, we provide definitions of what an incomplete stay is for residents. So the first example of a resident having an incomplete stay is if the stay ends with an unplanned discharge. And this would be documented based on the type of discharge as being unplanned. Another reason that a resident may be considered to have an incomplete stay is if the resident is discharged to acute care, a psychiatric hospital, or a long-term care hospital. And on the slide you see the details in terms of how that would be operationalized using the data set items. Another reason that a resident may be classified as having an incomplete stay would relate to if there's a death in the facility, and that would be recorded on the MDS tracking record, and the details are also on the slide in terms of how that's documented. Also, if the patient's Medicare Part A stay is less than 3 days, then this is considered an incomplete stay also. So next, I'd like to highlight some of the changes that we'll be covering in today's webinar. So as I mentioned previously, there are new items in Section GG, in particular GG 0100, which is PARV, Functioning Everyday Activities. There's also a new item GG 0110 about prior device use. There is a new Code 10, and that is defined as the activity was not attempted due to environmental limitations, and that could be lack of equipment, or it could relate to weather constraints. We will also be talking about the fact that goals may now, in addition to being coded the 01 through 06, you are now allowed to code the activity not attempted codes as goals. So those include Code 7, 9, the new Code 10, as well as 88. Overall, squatting guidance addresses safety, and so one of the things that you may notice is that the definitions that we're talking about today sometimes do not include the word safely, and that's because it's addressed generally. So I'd also like to mention, and we'll go into this in more detail shortly, but coding and item definitions have been clarified and aligned, and that's based on all the great help desk questions that have been submitted to the help desk for the SNF QRP, as well as other settings, for example, the inpatient rehab facilities. And so we've had a lot of questions where we thought it would be helpful to clarify some of the terminology, and so those are now incorporated into this version of the data set. So one example is contact guard was added to the definition of 04, supervision and touching assistance. We had a few questions asking whether that would be included or not, and so we have included that, and it's now on the data set and part of the definition of 04. Another example is eating. So that is an item that has been on the MDS since October 1, 2016, and that definition has been clarified that it includes food and liquid. So you see that in bold and liquid. It has always been the intent to include liquid, but we had some questions about it, and so we thought it would be helpful to clarify the definition that it does indeed include liquid. And then you'll see at the end of that definition, it also talks about the meal is placed before the resident. Another update relates to oral hygiene. Again, this is an item that has been on the data set since 2016. You'll notice a slightly modified definition in relation to dentures, and it's just been reworded slightly to say the ability to insert and remove dentures into and from the mouth and manage denture soaking and rinsing with use of equipment. Another example relates to toileting hygiene. So again, this is an item that has been on the MDS since 2016, and we added clarification that it's not just about getting on it, using a toilet or commode, and so we clarified that this item can be scored anytime there's voiding or the resident is having a bowel movement. So we had several questions that came in over the last couple of years relating to whether this item could be coded when somebody is incontinent, and the answer is yes. And so, again, we provided that wording to make clarification and letting you know one example. Sit to stand has also had a slight revision to include wheelchair. So that can occur if somebody is sitting in a chair, in a wheelchair, or on the side of the bed. And finally, a minor edit was made. We, on the 2016 data set, had wheelchair/scooter, and that has just been reworded to say wheelchair and or scooter. So on the next slide, you'll see that we're now moving to talking in detail about the items, prior functioning, everyday activities. So you see on the slide now the screenshot, which is taken from the 2018 data set, and you'll see that there are the coding responses on the left side, and on the right side you'll see the items self-care, there's the definition there, indoor mobility, stairs, and functional cognition. So each of these four areas are coded using the coding responses on the left side. You'll be gathering this data by asking the resident and his or her family about the resident's prior functioning with everyday activities prior to the current illness, exacerbation, or injury. You may also gather this information by reviewing the resident's medical records describing the resident's prior functioning with everyday activities. The codes, just to go over those briefly. So for these particular items, the codes are 3, meaning independent, which would be coded if the resident completed the activities by him/herself, with or without an assistive device. Code 2 would be used if the resident needed some help with and that would be partial assistance from another person to complete the activity. And a code 1 would be used if the person is dependent, meaning that somebody else assisted the resident to perform the activity, or the assistance of 2 or more helpers was required to complete the activity. If the resident is unable to provide the information, perhaps family is not available, there is an option code 8 to indicate unknown. So that would mean that the resident's usual ability prior to the current illness, exacerbation, or injury is unknown. And then there's a code 9, not applicable, if the activity was not applicable to the resident prior to the current illness, exacerbation, or injury. So moving on to the next item, which is prior device use. This is a checkbox where you indicate the devices, mobility devices that the resident may have been using prior to the current illness, exacerbation, or injury. So the time frame for these 2 new items is the same. And the options are listed, you can see on the screenshot. It includes wheelchair, mechanical lift, walker, prosthetics, as well as orthotics. Here you can just see it's been blown up a little bit, but you would check all that apply. And again, these are prior device use. So the information for this is also gathered the same way by asking resident and or his family. It would be reviewing medical records if the resident and or family is not able to provide the information, and you would only report devices and aids used immediately prior to the current illness, exacerbation, or injury. Again, check all that apply. If none of these items apply, so if the person does not use a manual wheelchair, a motorized wheelchair and or scooter, a mechanical lift, walker, or orthotics or prosthetics, you would check Z, none of the above. Now we'll move to talking about the items that are collected on admission and discharge, that is GG 0130, self-care, and GG 0170, mobility. So what you see on this slide is that there are 3 items that are you have been used to collecting data on since 2016. There's 4 new items, and those are highlighted in yellow. We'll be going through each of those new items. And in the mobility area, you'll see that there's a new item, roll left to right, as well as several new walking items and some new items related to stairs. And those are highlighted also as new items. In terms of the steps for assessment, it is similar to what you have been used to doing for these items, and we have provided some additional edits in the steps for assessment guidance based on feedback and questions that have come in. So you're doing the assessment for the self-care and mobility performance based on direct observation. In the event that you're not able to observe the resident performing activities such as walking or toilet and hygiene, you can use information such as the resident self-report, reports from other clinicians, other care staff, family reports if they're assisting the resident perhaps in performing daily activities. And again, the information time frame is a 3-day assessment period. Residents should be allowed to perform the activities as independently as possible at the time of admission and discharge. If the helper assistance is required because the resident's performance is unsafe or of poor quality, score according to the amount of assistance provided. For Section GG, a helper is defined as facility staff who are direct employees and facility contracted employees. Activities may be completed with or without assistive devices. That would not affect changing somebody's score. Just code based on the type and amount of human assistance provided. If the resident's self-care and mobility performance varies during the assessment period, record the resident's usual ability to perform each activity. So in the event that somebody is dependent but that doesn't really reflect kind of their status, or if the person is independent but that really doesn't reflect their status, you wouldn't code that. The intent is to code person's typical ability at the point of admission or discharge. Refer to facility, federal, state policies and procedures to determine which staff members may complete an assessment. Resident assessments are to be completed in compliance with facility, federal, and state requirements. We typically get some questions about usual performance, so I did want to add some clarification here. So on admission, the intent of the admission assessment is to document the resident's status, and it should be based on a clinical assessment of the resident's performance that occurs soon after the resident's admission. The admission function scores are to reflect the resident's admission baseline status prior to any benefit from therapeutic interventions. At the time of discharge, code the resident's discharge functional status based on a clinical assessment that occurs as close to the resident's discharge as possible. A resident's functional status can be impacted by the environment or situations encountered at the facility, so observing the resident's interactions with others in different locations and different circumstances can be important for a comprehensive understanding of the resident's functional status. In the event that the resident's functional status varies, record the resident's usual ability to perform an activity. Next, you'll see the rating scale, which is a 6-point rating scale. We'll be going through each of these definitions a little bit more in detail, but basically 6 refers to independent, 5 refers to setup or cleanup assistance, 4 refers to supervision or touching assistance, 3 refers to partial moderate assistance, 2 refers to substantial maximal assistance, and 1 refers to dependence. If the activity was not attempted during the 3-day assessment period, either admission or discharge, indicate the reason that the person was not able to perform the activity. The options are 7 if the resident refused, 09 if the item was not applicable. That means that the activity was not attempted at the time of admission or discharge, and that the activity was not done by the resident prior to the current illness, exacerbation, or injury. Code 10, if the activity was not attempted due to some environmental limitation, that is, no equipment was available or there were weather constraints. And Code 88, not attempted due to medical condition or safety concerns, if it's an issue related to safety or a medical condition. We provide on the next few slides some key coding decisions to help you think through how to code. And so for all of the activities, when you're coding a resident, you would be able to kind of think through these questions and come up to the correct coding response. So the first question you would ask when thinking about coding an activity is, does the resident complete the activity by him herself with no assistance? And when we say no assistance, that means no physical assistance, no verbal, nonverbal cueing, and no setup or cleanup. If the answer is yes, you would code independent 6. If the answer is no, you would go to the next question, which is on the next slide, and you would then ask, does the resident need only setup or cleanup assistance from one helper? If the answer to that question is yes, you would say the code is 5. If the answer is no, then we would go to the next question, which is on the next slide, and that question would be, does the resident need only verbal, nonverbal cueing or touching, setting, contact guard assistance from one helper? If the answer to that question is yes, you would code 04, supervision or touching assistance. If the answer is no, we would move to the next question, asking, does the resident need physical assistance, for example, lifting or trunk support from one helper, with the helper providing less than half of the effort? If the answer to that question is yes, you would code 03. If you answer no to that question, you would then ask the next question, which asks, does the resident need physical assistance, for example, lifting or trunk support from one helper, with the helper providing more than half of the effort? If the answer to that question is yes, you would code 2. If the answer to that question is no, then you would then move to the last question, which is, does the helper provide all of the effort, or is the assistance of more than 2 helpers required to complete the activity? If either one of those responses is yes, you would code 01. So just to kind of point out one of the examples of questions that have come in and how this decision tree can help you. If the assistance of 2 or more helpers is needed, you'll notice that at each level, even if assistance is provided, as always talks about 1 helper until you get to the last question. So in the event that there are 2 helpers helping 1 resident with 1 activity, you're going to code that level 1, even if the resident is doing some of the activity. The decision trees will help you get to level 1, which is the correct code for that example. Okay, I mentioned before that there are activity not attempted codes. So the 3 codes that have been on the data set since 2016 are 7, resident refused, 09, not applicable, and 8, not attempted due to medical conditions and safety concerns. Code 88 is certainly the most used code. There are new items on the data set that relate to car transfer and walking on uneven surfaces. So a code 10 may be used for those items in the event that you, for example, do not have access to a car or a car simulator for the resident to practice getting in and out of a car, or in the event that for walking on uneven surfaces, perhaps somebody is taken outside and there's inclement weather. And so that's just a couple of examples of use of Code 10, not attempted due to environmental limitations. Do want to review some coding tips, just in general, for both the self-care and mobility activities. So when observing the resident, reviewing the medical resident, or interviewing staff, be familiar with the definitions for each activity. And when we go through some practice case scenarios in a little bit, you'll see that there's some examples where there's extra information that that would be ignored when you're considering coding a particular item, because the information that's provided is not part of the definition of the item. On admission, when coding the resident's usual performance and the resident's discharge goals, use the 6-point scale or one of the activity not attempted codes. And again, those activity not attempted codes are 7, 9, 10, and 88. And those codes provide information about why the activity was not attempted. At the time of discharge, use the 6-point scale or the activity not attempted codes to identify the resident's usual performance at discharge. Do not record the resident's best performance and do not record the resident's worst performance, but rather record the resident's usual performance during the assessment period. So one example that I can speak to on this issue is that when a resident is first admitted, perhaps the resident may be getting used to the environment and the staff, and so the resident may not be performing at their best ability at that point in time, and so it may be after a couple of hours that the person is a little bit more settled, and so they're able to perform a little bit more representing what their usual status would be. Do not record the staff's assessment of the resident's potential capability to perform an activity. You should be coding based on actual performance. If 2 or more helpers are required to assist the resident to complete an activity, code 01 dependent. And that was covered again in the decision tree. If the resident does not attempt the activity and the helper does not complete the activity for the resident during the entire assessment period, code the reason the activity was not attempted. To clarify your own understanding of the resident's performance of an activity, ask probing questions of staff about the resident, beginning with general and proceeding to more specific. In the training manual, there are some examples of some potential interviews that could be done as part of that to help address that. Next, on this slide, you'll see that the self-care items are listed, and the first column, which is highlighted in yellow, relates to the performance. The second column relates to goals. So the definition of eating, as I mentioned, has been updated, so that is the ability to use suitable utensils to bring food and or liquid to the mouth and swallow food and or liquid once the meal has been placed before the resident. So there's, the coding does not change, we've just clarified the definition. In the training manual, we've also provided some coding tips. Again, this is based on all the great help desk questions that have come into the SNF QRP help desk. And so we just wanted to highlight that the eating item refers to eating and drinking by mouth only. If the resident eats and drinks by mouth and relies partially on obtaining nutrition and liquids via a tube feeding or TPN, code eating based on the amount of assistance the resident requires to eat or drink by mouth. Assistance with tube feedings or TPN is not considered when coding the eating item. If the resident eats finger foods with his or her hands, code based on the amount of assistance provided. The next item is oral hygiene. Again, this is an item that has been on the data set since 2016, and there's a slight revision in the wording of the definition. The next item is toileting hygiene. Toileting hygiene, again, has been an item that's been on the data set, and there's just been clarification in terms of wording. So the definition is the ability to maintain perineal hygiene, adjust clothing before and after voiding or having a bowel movement, is managing an ostomy, include wiping or opening, but not managing the equipment. And again, the part that has been slightly modified for clarification is the words voiding or having a bowel movement. We did add coding tips into the manual, so I just wanted to review those quickly here. So the activity of toileting hygiene refers to managing clothing. It can also relate to incontinence products. If somebody uses incontinence products, it relates to performing perineal hygiene, and it would take into account both that cleansing if somebody's voiding or having a bowel movement. It can take place before and after using a toilet, commode, bedpan, or urinal. If the resident does not usually use undergarments, then assess the resident's need for assistance to manage whatever lower body clothing is used, as well as, of course, perineal hygiene, which is part of the activity. If the resident has an indwelling urinary catheter and has bowel movements, code toileting hygiene based on the amount of assistance needed by the resident when moving his or her bowels. If the person has a catheter, they're not voiding, and so that's why you would be able to code based on the bowel movements then. So we do have a practice coding scenario, and so if you would like to just write down your response, we'll be going through that with you with the rationale in a few minutes. So in this particular example, Ms. Q has a progressive neurologic disease that affects her fine motor and gross motor coordination, balance, and activity tolerance. She wears a gown and underwear during the day. Ms. Q uses a bedside commode as she steadies herself in standing with one hand and initiates pulling down her underwear with another hand. But she needs assistance to complete this activity owing to her coordination impairment. After voiding, Ms. Q wipes her perineal area without assistance while sitting on the commode. While Ms. Q has a bowel movement, a certified nursing assistant performs perineal hygiene as Ms. Q needs to steady herself with both hands to stand for this activity. Ms. Q is usually too fatigued at this point and requires full assistance to pull up her underwear. So this is this example is inspired from a question that came in, which I thought was really good. So in the event that somebody needs different levels of assistance for when they void versus have a bowel movement, you would code the lower, more dependent level for this type of scenario. So in this case, we would think about what's going on for toileting hygiene related to bladder as well as bowel. In this case, the person needed a bit of help to pull down their clothing. She was independent in cleansing for bladder, and she needed total assistance to pull the clothing back up. But she actually needed more help with when she had a bowel movement, and so that's actually what the coding would end up being reported on the MDS. So in this case, she needed a bit of help with pulling her clothing down when she was about to have a bowel movement. She needed total assistance basically for the cleansing, as well as total assistance to pull the clothing back up. So how would you code this example, and what is your rationale? So perhaps you think 04, 03, 02, or 01. I'll give you just a sec to write down your answer or to think about it. Okay. In this case, the correct response would be 02. And And that is the rationale is that the helper provided more than half of the effort needed for the resident to complete the activity of toileting. So again, there was 3 tasks, and the person was needing just a bit of help with the first, pulling down the clothing, and then was dependent basically with the part of cleansing for the bowel movement, and dependent with pulling the clothing back up. So that was kind of a hard example, but I thought it was a great question that had come in, and it would be good to cover. So the next activity is shower, bathe, self. And so this is a new item, and this is defined as the ability to bathe the person, including washing, rinsing, and drying. It does not include washing the back or hair, and it does not include transferring into or out of a tub or shower. There are some coding tips in the training manual, and I'll just highlight some of those here. So again, it includes washing, rinsing, and drying, and it does include the face, upper body, lower body, as well as the perineal area and feet. As I mentioned, it does not include the back or hair, and does not include getting in and out of the tub or shower. The assessment of shower bathe self can take place in the shower or bath, at a sink, or at the bedside, so a sponge bath would be coded. If the resident bathes him or herself and a helper sets up material, for example, bringing some water to the resident's bedside, that would be considered setup or cleanup assistance. If the resident cannot bathe his or her entire body because of a medical condition, then code shower bathe self based on the amount of assistance needed to complete the activity. So we do have an example here to go through together. So Mr. J sits on a tub bench as he washes, rinses, and dries himself. A certified nursing assistant stays with him to ensure his safety, as Mr. J has had instances of losing his balance. The certified nursing assistant also provides lifting assistance as Mr. J gets onto and off the tub bench. How would you code Mr. J for shower bathe self, and what is your rationale? As you think about coding this item, think about the definition, and I hope that you're thinking that that last sentence is not helpful for coding. As I mentioned before, do not code for this particular item assistance required to get on and off a tub bench. And so you are basically taking into account assistance that's being provided based on what's happening during the shower bathe. Possible responses would be 04, 03, 02, and 01. How would you code for Mr. J? If you coded 04, that would be correct, supervision or touching assistance. So in this case, the helper provides supervision as Mr. J washes, rinses, and dries himself, and again, the transfer on and off the bench was not considered, and so you would not take that into consideration. Next, we'll move to upper body dressing. So upper body dressing is defined as the ability to dress and undress above the waist, and it includes fasteners if those are applicable for a resident. We have a practice scenario also for upper body dressing. Mr. K sustained a spinal cord injury that has affected both movement and strength in both upper extremities. He places his left hand into 1/3 of his left sleeve of his shirt with much time and effort, and is unable to continue with the activity. The certified nursing assistant assists when completing the remaining of upper body dressing for Mr. K. How would you code this item for Mr. K, and what is your rationale? Possible responses include 04, supervision or touching assistance, 3, 2, or 1. So in this case, the resident was starting to put his shirt on, but it took a lot of time. It was very difficult, and so somebody helped with a fair amount of the activity. So in this case, the correct response is O2, substantial maximal assistance. Mr. K can perform a small portion of the activity of upper body dressing and requires assistance from a helper for more than half of the effort. The next activity is lower body dressing. Lower body dressing is defined as the ability to dress and undress below the waist and includes fasteners. It does not include footwear. You'll see actually right below there is a separate item related to footwear. So lower body dressing basically is from the waist to basically the ankle. So we also have a practice coding scenario for this activity. So Mrs. R has peripheral neuropathy in her upper and lower extremities. Each morning, Mrs. R needs assistance from a helper to place her lower limb into or to take it out of her lower limb prosthesis. She needs no assistance to put on or remove her underwear or slacks. So if we think through the decision trees, we do consider the prosthesis in this case to be part of the dressing, undressing activity, and so it's considered almost like a piece of clothing. And so this resident, Mrs. R, does need assistance. It's more than setup. It's more than supervision. And so when you consider that there is a prosthesis, there is underwear and slacks, the helper is providing assistance with the prosthesis, and it says that Mrs. R is putting on and removing her underwear and slacks. So how would you code this item for Mrs. R, and what is your rationale? So maybe you would code it 05, 04, 03, or 02. In this case, the correct response is 03, partial moderate assistance. And the rationale is that a helper performs less than half of the effort of lower body dressing, and that, again, the assistance is the prosthesis. The helper lifts, holds, or supports Mrs. R's trunk and limbs, but provides less than half of the effort for the task of lower body dressing. In contrast, coding 04, supervision or touching assistance, is used if the helper provides either verbal cueing and or touching assistance, steadying assistance only. Okay, so now we're on to the last item in the area of self-care, and that item or that activity is putting on and taking off footwear. So that is defined as the ability to put on and take off socks and shoes or other footwear that is appropriate for safe mobility. It does include fasteners if applicable. So here we have another example. Mr. M is undergoing rehabilitation for right side upper and lower body weakness following a stroke. He has made significant progress towards his independence and will be discharged to home tomorrow. Mr. M wears an AFO, and he has put on his foot and that he puts on his foot and ankle after he puts on his socks, but before he puts on his shoes. He always places his AFO, socks, and shoes within easy reach of his bed. While sitting on the side of the bed, he needs to bend over to put on and take off his AFO, socks, and shoes. And he occasionally loses his sitting balance, requiring staff to place their hands on him to maintain his balance while performing this task. So how would you code putting on, taking off footwear, and what is your rationale? Possible options for coding are 05, 04, 03, and 02. In this case, the correct response is 04, supervision or touching assistance. The rationale being that Mr. M puts on and takes off his AFO, socks, and shoes by himself. However, because of occasional loss of balance, he needs a helper to provide touching assistance when he is bending over. Okay, next we're moving to talking about the self-care discharge goals. So the goal items have been on the data set since 2016. So as I mentioned before, one of the differences that you are now permitted to code the activity not attempted codes in addition to the 6-point rating scale. So you can code 01 through 06 or 07, 09, 10, or 88. For the SNF QRP, a minimum of one self-care or mobility goal must be coded. However, facilities may choose to complete more than one self-care or mobility discharge goal. Use of a dash is permissible for any remaining self-care or mobility goals that are not coded. Using the dash in this allowed instance after coding of at least one goal does not affect your annual payment update APU determination. Goals can be set by licensed qualified clinicians based on the resident's prior medical conditions. That may be prior and current self-care and mobility status, discussions with the resident or family concerning discharge goals, professional standard of practice, expected treatments, expected length of stay, resident's planned discharge destination. Goals should be established as part of the resident's care plan. A goal in some cases for an item may be that the person is expected to improve in their ability and the discharge code is actually higher than the admission performance code, and that's the instance where the clinician and resident determine that the resident is expected to gain function. A discharge goal could be the same as the admission performance. Perhaps somebody is already independent with an activity, and so the goal is to maintain independence. It is also possible, depending on the person's condition, that the person is perhaps expected to have a decline in function, and so in that case it's possible that the goal might be lower than the admission performance code. Okay, so now we're going to be moving to the mobility section, which is GG 0170. And in this case, again, you have on this slide the first column, admission performance, is highlighted in yellow. These are the remaining items, so the mobility items, there are more mobility items. You'll see actually also that there are some gateway questions and follow-up items for the wheelchair-related items that has been on the data set since 2016. So I want to begin with one of the new items that was added to mobility, which is GG 0170A, roll left to right. This item is defined as the ability to roll from lying on back to left and right side and return to lying on the back of the bed. We do have a practice coding scenario here. Mr. Z had a stroke that resulted in paralysis on his right side, and he is recovering from cardiac surgery. He requires the assistance of 2 certified nursing assistants when rolling onto his right side and returning to lying on his back, and also when rolling onto his left side and returning to lying on his back. How would you code this item, roll left to right, for Mr. Z, and what is your rationale? So possible response options that you can choose from are 01, 04, 09, and 88. In this case, the correct response is 01. And hopefully, this was an easy one for you. This is the rationale being 2 certified nursing assistants were needed to help roll Mr. Z to his left and right side. So we're skipping over a few items because they have been on the data set, so we're just actually moving to GG0170G, car transfers, which is a new item on the data set this year. And car transfers refers to the ability to transfer in and out of car or van on the passenger side. It does not include the ability to open and close the door or fasten a seatbelt. So we have an example here. During her rehabilitation stay, Mrs. N works with an occupational therapist on transfers in and out of passenger side of the car. On the day before discharge, when performing car transfers, Mrs. N requires verbal reminders for safety and light touching assistance. The therapist instructs her on strategic hand placement while Mrs. N transitions to sitting in the car's passenger seat. The therapist opens and closes the door. How would you code car transfer, and what is your rationale? Possible options for responses are 05, 04, 02, and 01. In this case, the correct response is 04, supervision and touching assistance. The rationale is that the helper provides touching assistance as the resident transfers into the passenger seat of the car. Assistance with opening and closing the car door is not included in the definition of the item and is not considered when coding the item. The next new activity that we're going to cover is walk 10 feet. And what I'd like to highlight here is that there is a skip pattern that's important to pay attention to. So for this particular item, walk 10 feet, if the resident is not able to perform the activity, so that means that the activity is coded 7, 9, 10, or 88. Then there's a skip pattern. If the person is not able to walk 10 feet, then we don't expect they'd be able to walk the 50 feet with 2 turns or the 150 feet. Therefore, you skip over those items to the one-step curb. So again, if the activity does occur 10 feet, then you would code the other items, but in the event that the resident is unable to walk 10 feet, and that would be, there's a code of 7, 9, 10, or 88, then you would skip past the other walking items on the data set to the curb. I'd like to highlight that if you skip over the admission performance item, you can certainly still code any of the walking items as a discharge goal. The second bullet highlights that there was previously a gateway question, which was GG0178, which has been removed, and basically the skip pattern that I just described replaces the item that was removed. So there's just some coding tips for the walking items. So walking activities do not need to occur during one session. So for example, if the assessment is occurring during a therapy session, one activity, perhaps a shorter distance, could be assessed in the morning, and a different time could be used to assess walking 50 feet with 2 turns. When coding the GG0170 walking items, do not consider the resident's mobility performance when using parallel bars. Again, this was a coding tip that we created based on the help desk questions. Basically, since parallel bars they're not portable, so somebody cannot take those parallel bars with them if they wanted to walk down a hallway, and so that's why those are not considered. The turns included in the items GG0170J, walk with 2 turns, are 90-degree turns. The turns may be in the same direction, or they may be in different directions. So again, you're walking 50 feet with 2 turns. It could be 2 left turns, it could be 2 right turns, or it could be 1 left turn and 1 right turn. We do have an example to go through together for walk 10 feet. In this example, Mr. L has bilateral amputations 3 years ago, and prior to the current admission, he used a wheelchair and did not walk. Currently, Mr. L does not use prosthetic devices and uses only a wheelchair for mobility. Mr. L's care plan includes fitting and use of bilateral lower extremity prostheses. How would you code walk 10 feet? So this is another example that was inspired by help desk questions that we got. And so what you would be thinking through is that the activity doesn't occur now. And so one of the options is that it's due to a medical condition or safety concern. But you would also, in this case, take into consideration that this Mr. L, it says he did not walk prior to his current illness, exacerbation, or injury. And so that actually leads you to another response for coding the reason that the activity was not attempted. So perhaps the response that you would come up with is 01, 09, 88, or 07. I'll just give you a second to consider what you would like to code that. Okay, so in this case, the correct response is 09, not applicable. And the rationale is that in this case, the resident's prior status was that he was not performing this activity prior to the current illness, exacerbation, or injury, and so that would be the code 09, not applicable. Certainly somebody can have a goal of walking. In this case, this gentleman did have a goal in this particular example. So you can still have a goal even if it's not applicable. Okay, the next new item that has been added onto the data set is walking 10 feet on uneven surfaces, and that is defined as the ability to walk 10 feet on uneven or sloping surfaces that could be indoor or outdoor, and it could be surfaces such as turf or gravel. We have an example here. Mrs. N has severe joint degenerative disease and is recovering from sepsis. Upon discharge, Mrs. N will need to be able to walk on uneven and sloping surfaces of her driveway. So during her SNF stay, a physical therapist takes Ms. N outside to walk on uneven surfaces. Ms. N requires the therapist's weight-bearing assistance less than half of the time during walking to prevent Mrs. N from falling as she navigates walking 10 feet over uneven surfaces. How would you code Mrs. N? Possible options for response are 04, 03, 02, and 01. Okay. In this case, the correct code would be 03, partial moderate assistance. The rationale being that Mrs. N requires a helper to provide weight-bearing assistance several times to prevent her from falling as she walks the 10 feet on uneven surfaces. The helper contributes less than half of the effort required for Mrs. N to walk those 10 feet on the uneven surfaces. The next activity is one-step curb, the ability to go up and down one curb and or down one step. If admission performance of this item is coded 07, 09, 10, or 88, you would skip actually the next few items, which are other stair items. Okay, sorry, just a little delay in the slides there. So again, the definition is about going up and down a curb. It's possible if somebody is in a wheelchair that may be assessed in a wheelchair. And so that's why it's worded as go up and down, could be stepping, could be going up and down in a wheelchair. And again, I noticed as we went through the definition that there is a skip pattern because there are two other items related to walking up and down stairs. So we do have one practice scenario here. Mrs. Z has had a stroke. She She must be able to step up and down one step to enter and exit her home. A physical therapist provides standby assistance as she uses her quad cane to support her balance in stepping up one step. The physical therapist provides steadying assistance as Mrs. V uses her cane for balance and steps down one step. How would you code this item for Mrs. V? Possible options for coding are 04, 03, 02, and 01. In this case, the correct response is for supervision or touching assistance, and that's based on the helper provided touching assistance. As I mentioned, there's another step item here, which is 4 steps. And again, the skip pattern, if somebody is not able to go up and down one step, then you get to skip over the 4 steps as well as the next item, which is 12 steps. So again, in the event that somebody is able to go up and down 4 steps, you would be coding also 12 steps. In the event that somebody is not able to go up and down 4 steps, meaning the codes would be 07, 09, 10, or 88, you would skip over the 12-step item to the pickup object item. And here is the 12-step item. Again, with all the stairs items, it can be with or without railing. In this practice scenario for 12 steps, Ms. Y is recovering from a stroke resulting in motor issues and poor endurance. Ms. Y's home has 12 steps with a railing, and she needs to use these stairs to enter and exit her home. Her physical therapist uses a gate belt around her trunk and supports less than half of the effort as Ms. Y ascends and then descends 12 stairs. How would you code this item for Ms. Y? Possible responses are 5, 4, 3, and 2. In this case, the correct response is 3. And again, the helper in this case provided less than half of the effort as the resident ascended and descended 12 stairs. The last activity is pick up object, and so that is defined as the ability to pick up an object from a standing position. We do have a practice coding scenario here. Ms. C has recently undergone a hip replacement. When she drops items, she uses a long-handed reacher which she has been using at home prior to admission. She is ready for discharge and can now ambulate with a walker without assistance. When she drops objects from her walker basket, she requires a certified nursing assistant to locate her long-handled reacher and bring it to her in order for her to use it. She does not need assistance to pick up the object after the helper brings her the reacher. So how would you code pick up object? If you think through the decision tree, you think through whether she needed help and what level assistance. So possibly she could be any one of these codes that you see on the slide, 6, 5, 4, or 3. In this case, the correct response is setup or cleanup assistance code 5, and that's because there is setup assistance. Somebody had to get the reacher for her to use. In terms of goals, we've already talked about the goals related to self-care. The same instructions apply to the mobility items, and so you see there's 2 slides that have screenshots related to the discharge goals. So the summary for Section GG, we've covered that the Section GG items assess the need for assistance for self-care and mobility activities. Knowledge of the resident's functional status prior to the current event can inform treatment goals. So next we're moving to Section I. There is a new Section I item in the area of active diagnoses, and so we'll just spend a short time going over some coding guidance related to that new item. So the intent of Section I relates to items in the section are intended to code diseases that have a direct impact on the resident's functional status, cognitive status, mood or behavior status medical treatments, nursing monitoring, or risk of death. One of the important functions of the MDS assessment is to generate an updated, accurate picture of the resident's current health status. So the new item that has been added to the data set relates to the resident's primary medical condition. And there are categories of codes, as you can see on this slide. And again, this is the new item I0020. So there are 14 categories that would be chosen from, and the item rationale relates to health-related quality of life, and that is because disease processes can have a significant impact and effect on the resident's functional improvement. It also relates to planning care, and this item is used as a risk adjuster for the new functional outcome measures that I mentioned earlier that were adopted into the SNF QRP. In order to code the item, you would review documentation of the medical record to identify the resident's primary medical condition associated with the admission. There are many sources that you may be able to refer to, including the most recent history and physical, transfer documents, discharge summary, progress notes, as well as other resources as available. The categories, just as some examples, include stroke, brain dysfunction, neurologic conditions. There are also orthopedic conditions, as well as multiple trauma, debility, and medical complexity. In terms of coding instructions, you're only coding this item on the admission assessment. That is the start of the Part A PPS day. You're entering one category code. If the codes 1 through 13 do not apply, enter code 19, other medical condition, and then proceed to the follow-up item I0020A, and you would enter an ICD code into I0020A. So just to go into the categories in a little bit more detail, you would code 1 for stroke, and examples of a stroke include an ischemic stroke, a subarachnoid hemorrhage, a cerebral vascular accident, or other cerebral vascular disease. Code 2 would be used for a non-traumatic brain dysfunction. This could include something like Alzheimer's disease, dementia with or without behavioral disturbances, a malignant neoplasm of the brain, or anoxic brain damage. Code 3 relates to a traumatic brain dysfunction, and that could be as a result of a severe concussion or a cerebral laceration and contusion. Code 4 is a non-traumatic spinal cord dysfunction, and that could be due to something like spondylosis with myelopathy, transverse myelitis, a spinal cord lesion due to stenosis, as well as dissection of an aorta, which leads to a spinal cord lesion. Code 5 is a traumatic spinal cord dysfunction, and that may be paraplegia or quadriplegia as a result of trauma. Code 6 is progressive neurologic conditions, and examples of progressive neurologic conditions would be multiple sclerosis and Parkinson's disease. Code 7 is other neurologic conditions such as cerebral palsy, polyneuropathy, or myasthenia gravis. Code 8 is amputation, which could be an acquired absence of limb. Code 9 is hip or knee replacement. And I do want to highlight that in the event that a resident has had a hip replacement secondary to hip fracture, you would actually code the hip fracture and not the hip or knee replacement. Code 10 is fractures and other multiple trauma. So again, this is in the event somebody had a hip fracture and then had a hip replacement, you would code 10. You would not code the hip replacement, but you would code 10, fractures and other multiple trauma. There could also be, in this category, a pelvic fracture or fractures of the tibia, fibula. Code 11 is other orthopedic conditions. Code 12 is debility and cardiorespiratory conditions, so this is potentially somebody who's had COPD or some other respiratory cardiac conditions such as asthma. Code 13 is for medically complex conditions, and this could be a constellation of conditions, for example, diabetes, pneumonia, kidney disease, potentially wounds, pressure ulcers, or electrolyte imbalances. And then Code 14 is the other medical condition, and as I mentioned before, if the resident's primary medical condition is not one of the listed categories, you would be entering an ICD-10 code into I-020A. We do have a few practice case scenarios here. So the first one, Ms. K, is a 67-year-old female with a history of Alzheimer's, dementia, and diabetes who is admitted after a stroke. The diagnosis of stroke, as well as the history of Alzheimer's, dementia, and diabetes, is documented in Mrs. K's history and physical by the admitting physician. So in this case, you would pay attention to the fact that the person may have a history of some information, but the reason that they are being admitted to the SNF now actually relates to the stroke. So in this case, you would be coding stroke as the primary diagnosis. So again, that is the primary reason the person's admitted, even though the person does have other comorbidities. Another example, Mrs. H is a 93-year-old female with a history of hypertension and chronic kidney disease who is admitted to the facility where she will complete a course of intravenous antibiotics after an acute episode of urosepsis. The discharge diagnosis of urosepsis, chronic kidney disease, and hypertension are documented in the physician's discharge summary from the acute care record and are incorporated into Mrs. H's medical record. So oftentimes, many of these diagnoses will be documented in the acute care medical record, and they will be also documented in the SNF medical record. So how would you code this particular resident? In this case, it would be 13 medically complex conditions. The physician's discharge summary from the acute care record documents IV antibiotics due to various conditions, including urosepsis. We have another coding scenario. Mr. T is an active 83-year-old male who fell from a ladder after changing a ceiling light bulb at home and sustained a hip fracture and underwent a total hip replacement. The discharge diagnosis from the acute care record of status post fracture with total hip replacement are documented in the discharge summary from the acute care hospital and are incorporated into Mr. T's medical record. He is admitted to the SNF for rehabilitation. What would you code for the primary diagnosis for this gentleman? Would you code hip replacement or fractures and other multiple trauma or other orthopedic conditions? In this case, you would code 10 fractures and other multiple trauma. As I mentioned before, in the event that somebody has a hip replacement, but the reason for the hip replacement is the hip fracture, you would actually code the hip fracture. So the rationale, the documentation in the medical record received from acute care indicates that Mr. T's total hip replacement was a result of the hip fracture. For coding instruction of 09, hip and knee replacement, if hip replacement is secondary to hip fracture, code as a fracture. So again, that was the correct code there was 10. So in summary, just in this presentation, you learned about coding instructions for new items in section GG and item I-020, and the purpose was to provide some information about accurately coding, and so we provided coding scenarios in order to help you do that. At this point, I will turn the session back over to Sharon.
Okay, great. So before we wrap up today, I want to thank Ann, and thank you so much for sharing your valuable knowledge in today's webinar. And also just want to let everyone know that the full version of the slides, including the answers to the polling questions, as well as a recorded version of this webinar, will be posted. We will send an email notifying you when and where those items have been posted. Also, remember to check the SNF QRP webpage for the Q&A document from the July 31st, August 1st in-person training for answers to questions. This concludes the Skilled Nursing Facilities Quality Reporting Program, Section GG, New Items, and Section I, Updates webinar. Thank you all very much for attending. Have a good day.
This concludes today's webinar. Thank you for attending.